Good evening, everybody, and welcome to our webinar tonight, Winter Preparedness for Primary Care. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past and present. And I'm coming to you from Wonnarua land at beautiful Maitland. We have three presenters for you tonight. We have two public health physicians, Tony Merritt from Hunter New England Population Health and Richard Broome from the Central Coast Public Health Unit. We also have our regular wonderful GP, Dr. Michelle Redford, who will also be doing a presentation. There will be an evaluation that will pop up at the end. If you could please fill it in. We love to get your feedback. And please type in any questions in the question box. Again, it's a great opportunity when we have these two wonderful physicians here to ask any questions that you might have. All right, I think that's all that you need to hear from me. The session is being recorded and will be available in our library from Friday. All right, thanks, Richard and Tony.
Terrific. Well, look, I'm going to start off and then I will pass to Richard. So lovely to be with you again after a bit of a break, and great to share the floor with Richard. So we'll provide a combined sort of Hunter New England Central Coast perspective. My section is going to focus on COVID. So I just wanted to give you a little bit of a sense of what's been happening, focus on the Omicron period in terms of activity through this time, what data sources are kind of useful, what the recent wave's been like and where we're up to, perhaps what's coming down the track, and just a couple of prevention methods we ought to be thinking. Let's just move to there. I'm on wonderful Awabakal country, and I pay my respects to elders past and present as well. So here's data for the last 2 years or so. It's notification data. This is Hunter New England test data, but it's a very similar picture in the Central Coast and in fact for New South Wales as a whole. It gives us a really clear picture of the kind of waves of COVID we've been navigating over this period of time. I've numbered them there 1 to 5. We're going to look at a couple of different data sources to get kind of richer perspective on these Omicron waves. And the test data is fabulous for at least giving us a sense of the frequency of waves, and it's really clear from this progression that the period between wave peaks is stretching out. 3 months at the start of this period, dating back to kind of the end of Delta, start of Omicron in December 21, through to the 5th and most recent wave, where there's that followed about 6 months after wave 4. So really clear picture in terms of the trend there with increased frequency. We're very constrained in terms of how much testing data can tell us, of course, about the actual magnitude of these waves. The green marks on this chart are rat tests, and of course we recognise rats are displaced PCR and are underreported. And then again in recent times since May, the access to PCR has been dramatically reduced. So testing is really constrained in terms of magnitude, of course, but the pattern in terms of the waves, I think, is clear and is interesting. So in terms of other data sources which do help illuminate the magnitude of recent waves, we'll just run through a few. First of those is flu tracking data. I think many of you will be flu trackers. If somehow you've got this far and you're not a flu tracker, then a quick Google will take you to the join up page. It takes me literally 20 seconds a week to respond on behalf of my wife and I and contribute to this community level surveillance. So it's, of course, giving a sense of the syndromic impact of respiratory viruses. It's ILI, if you like, fever and cough, at a community level, so not vulnerable to changes in access to health services and testing. And of course, it's not specific just to COVID, but for the first couple of years of the pandemic, there was very little other respiratory virus activity around. So it does measure other pathogens that might cause influenza-like illness, like flu, of course. And on that top line, so this is data that goes back pre-pandemic, but you can really clearly see those waves there to the right-hand end of that spectrum, BA1, 2 and BA4, 5 waves. So there's the wave numbers on the top for you too, giving it, in comparison to the test data, a really clearly different perspective about the magnitude of those waves, albeit with some impact from influenza in more recent times. And then the chart down the bottom introduces an additional element that the flu tracking data provides. So the blue line at the bottom is that test data again at a New South Wales level. You can see the patterns that this doesn't capture wave 5, so just 4 waves there. And the data at the top is for those flu trackers who get a COVID PCR test. This is the positivity of those tests. So this is very specific to COVID. And again, here you can see that the flu tracking data gives us a much clearer kind of measure of the comparability of these waves, certainly 1 through 4, with magnitude really very comparable and not influenced by the reduction in access to testing there. So flu tracking, really important perspective at a community level. We also rely very significantly on data around both hospitalisations and aged care outbreaks, and that's what these two charts are here. Hospitalisations on the top, aged care COVID outbreaks on the bottom. This is again Hunter New England data, but really similar pictures occurring across Central Coast and New South Wales as a whole. And it's a really striking pattern there on the top with hospitalisations. Waves are numbered again. You remember just how really impacted we all were by that large wave in winter last year. So wave 3 of Omicron coincided with influenza activity and everything else that was happening during winter. Incredible impact on hospitalisations and aged care outbreaks. And I guess the point I'd make here is that the wave structure is really clear. You can again see that change in periodicity between wave peaks. You can see that the third wave was indeed really significant in terms of impact on hospitals and aged care outbreaks, but also gives a really better insight into just the magnitude of what we've been dealing with in this slow burn of a wave 5 that we think the peak has now passed. Really very comparable to other waves during this Omicron era. Aged care outbreak data at the bottom there. Again, in this latest wave 5, we've had in excess of 30 aged care outbreaks open at any one time for a period of a couple of weeks. And that's under the new regimen where outbreaks can be closed much more quickly. If we'd been dealing with the response guidelines that were in place, say in winter last year, it may well be that we'd exceeded the number of open outbreaks that we were facing at that time. So hospitalisation data, aged care outbreak data, really critical to complement the testing data, other data sources as well. I'll touch on deaths in just a moment. We do have ongoing access to wastewater surveillance for quantitative COVID testing, staff furloughing and other sources, but we rely heavily on what's on the screen there. Genomics has been really fascinating. This is not for the whole period, it's just for the last couple of waves, and it's been a real feature, hasn't it, that the genomic pattern has changed for these waves. And if you just focus on the right-hand end of that graphic for wave 5, you get a sense of just the diversity of genotypes or variants of COVID that were contributing to this wave. The different green and blue shades represent different recombinant variants. Lots of those in this wave were in the XBB lineage. And this kind of soup of variants just makes it very difficult to reliably predict the behaviour of waves and whether one might emerge as a dominant over time, as was the case with the first Omicron waves. Look, I said I'd mention deaths. If you haven't seen, this is national data from the Actuarial Institute, and it's a striking report, publicly accessible online. I recommend it to you, in terms of getting a sense of this high-level mortality data that's available. The chart there that's on the screen gives a sense over the 3 years of the pandemic. The solid blue line that's moving across the screen there is the kind of middle estimate of expected deaths, with the light blue, the kind of likely range for deaths. Again, it's national data, established baseline over many years. And you can see that seasonal, of course, going up in winter with the impact of usual kind of winter viruses and influenza in particular. And then for each of these sections, this is a different year of the pandemic, with the coloured dots are point estimates, point measurements of actual mortality. And in that first year in 2020, mortality was lower than predicted from pre-pandemic levels, so there was a reduction in mortality over that time, tracked along roughly expected until kind of Delta period. And you can see from late 2021 and all through 2022, actual mortality tracking well above what was expected. So the extent you get the headline shared there with them estimating in the order of 20,000 excess deaths in Australia in 2022. And you can see in that chart that that trend continues, albeit at perhaps at a slightly lower level into the first few months of 2023, where there were at least 1,500 excess deaths over the first 2 months. There's additional data in there about who is impacted, and that those excess mortalities you'd expect is certainly focused in particularly in the older age groups above 75. But excess mortality was at least 5% higher in 2022 for all age groups, right down to the lowest that they use. So the impacts on mortality occurred right across the population. And what next? Well, it's been a brave person who confidently predicted what was going to happen next during the pandemic, of course, but certainly the suggestion with those waves behaving as I've described, that the frequency, the period between waves will continue to extend. And you might have seen this interesting article by some of our modelling colleagues in Victoria and New South Wales in The Conversation just a week or so ago, where they've bravely and speculatively offered the prediction that waves may well coincide with winter, become more predictable, and that may well be where we're heading with an annual seasonal wave, and the vaccination program would likely adjust to match that pattern as well. Very briefly, so Michelle will talk more about vaccination in a moment, but of course, in terms of responding to COVID, the key issues are going to be getting timely boosters and use of the non-pharmaceutical interventions, so masks in particular. I won't go into the detail there, but I guess the headline mantra is for those adults who haven't either had COVID infection or booster in the last 6 months, that a booster is recommended. Ideally one of the newer mRNA bivalent vaccines, of course. And there's some fabulous data that you can use with your colleagues and patients about the very real impact of recent boosters benefiting us all, particularly those 65 plus. So this is Australian data from NCS. It's in preprint at the moment, but available. Really large study, real world study on people last year. So it's Australian. It's in that age group. It's people who've very largely been exposed to boosters or infection in the past, a lot of hybrid immunity. And the impact from a recent booster had a very significant impact on preventing death and hospitalisation. So vaccine efficacy within 3 months of up to 90%, and still at around 50% 6 months out. So a recent booster is a really critical factor in preventing that high level morbidity. Clearly, masks still play an important role at a New South Wales health level. On our traffic light system, we're at yellow. That means surgical masks in clinical areas, N95 masks, and eye protection where COVID's suspected, and that translates locally into our workplace where we're not seeing patients through the doors with mask use now being dropped, but still a permissive environment, particularly for people in shared spaces where masks are readily available. And at a workplace, we use the CDC guidance for assessing high-level exposures both at work and at home. Like everyone, we're constrained with access to PCR, and really most decisions now are being made on the basis of rat testing, and where staff are recovering cases. Clearly, CDC has a permissive environment where return after day 5, if asymptomatic, can be considered with risk management. We have a bias with people working from home where that's possible until a return on day 10 if they're asymptomatic. Fabulous. So look, that's the end of my slides. Thanks for your attention. Look forward to questions later on. And Richard, I will hand to you.
Thanks, Tony. And I'll just begin by acknowledging I'm on dark and drunk country here on the Central Coast, and I'll pay my respects to Aboriginal elders past, present and emerging, and any Aboriginal people on the webinar tonight. So what I was hoping to do was really just give you a little bit of detail about what's been going on with the other respiratory viruses, particularly those that are notifiable, that's RSV and influenza, besides COVID. And a bit I would just start out by saying that RSV only became notifiable in September last year. So this is really the first winter where we've actually had information about it. So that means it's particularly challenging to know exactly what it means. We don't have a lot of context. But having said that, this graph is a picture of the notifications that we've had here in Hunter, New England and on the Central Coast since the beginning of the year. Blue is COVID, red's flu, green is RSV, and you can see the COVID notifications, bearing in mind all that Tony was saying about the caution you have to apply in interpreting what this notification data means. But COVID notifications have obviously fallen quite sharply now in the last month or so, but flu is going up and continues to go up. And RSV is interesting. It began to rise back in March and has been, steadily rose right up until the beginning of June, and just appears to be plateauing now and going down. So that's kind of the broad overview, and shows you the relationship, I guess, in terms of the relative number of notifications that we see for each of these viruses. So I hope that provides some context. So next slide, Tony. Thank you. This is a picture, and hopefully it might accord with your experience, but this is a picture for GP ILI presentations from the Aspirin network of Sentinel GP practices, and it comes from the Australian Surveillance Report, Weekly Surveillance Report. And what it's showing is the rate of ILI presentations to GPs per 1,000, and the red line is this year. And black is the average of recent years, but it doesn't include 2020 and 2021 because they were obviously affected by COVID in peculiar ways, shall we say. And you can see that we're actually tracking at the moment just above average in terms of GP presentations. And interestingly, I guess that average is, to my mind at least, fairly heavily skewed by the very early and unusually early flu season that we had in 2019, and then obviously the 2022 season, which was affected by COVID as well. So that's a bit of a worry. Obviously, if it continues to rise like this, we're going to be in for a very serious flu season. Obviously, we don't know at the moment whether that is going to happen, but that's the concern. And again, just to give you a bit of perspective, that the grey line, the very large grey line, is the 2017 flu season. Some of you may remember that was a particularly bad flu season that we had. And one thing I should have mentioned at the start, so whilst the notification data, you have to interpret with a bit of caution, we are seeing similar patterns in terms of hospitalizations and ED presentations for both flu and RSV as well. Next slide, Tony. I thought it's quite interesting just to look at the age differences in what's going on in different age groups, which I hope this slide will help with. So each of these graphs reflects a different age group. Top left is infants, so under 1 year of old. Bottom right is 85+-year-olds. And you can see that the notifications of RSV notifications dominate in infants, and fairly closely followed by COVID. Blue is just beginning to creep up now in those groups, and looks like it might well overtake in the next few weeks. Once you get into older kids, RSV is still important in the preschoolers, but particularly once you get into school-age children, flu becomes more important. And I think that probably goes with our understanding that a lot of flu transmission is driven by school-age people, which is probably important just in terms of what might happen in the coming weeks with school holidays. And then you can see that in adults up to the age of 85, COVID is the main event. We're not seeing much flu in RSV, bearing in mind testing patterns that might be in those age groups. And then we see a higher rate of COVID again in the over 85s. Now that might be driven by the fact that there's a bigger clinical need to test in those age groups. But I think the interesting thing to note here is that we also see in that age group the increase in RSV notifications. So obviously RSV is an issue in those other age groups, and we're actually seeing that in our aged care facility outbreaks as well. We're seeing certainly here on the Central Coast. I'm guessing, Tony, will be seeing the same thing in Hunter, New England, but we are seeing a few RSV outbreaks happening in aged care facilities at the moment. Again, just a bit more data on the trends that we're seeing. This is test positivity. And you can see that flu on the left-hand side has shot right up in the last 3 or 4 weeks, and currently about 12% of flu tests are positive. The other thing that graph shows is we're seeing a fairly even mix between flu A and flu B. COVID is tracking down in terms of positivity, currently about 10%. So flu has overtaken it just in the last couple of weeks. And then you might have to squint to see these graphs, but these are other viruses. And the top left is adenovirus, which you can see is going up. Bottom left is rhinovirus, which is sort of had a almost slightly similar pattern to flu, maybe it's dropped off in the last week or two. And then the other important one there is RSV down the bottom right. I guess what the important thing here is that rhinovirus, the scales are all different on these graphs. So rhinovirus is about 15% positivity rate. So I guess what that sort of, and you have to, it's not directly interpretable like this, but I guess if you've got someone with ILI, as it stands at the moment, there's a roughly even chance that they're going to have flu, COVID, or rhinovirus, a little bit of a lower chance of RSV, and then a relatively small chance of some of these other conditions. So I guess the question with flu at the moment is what is going to happen to it with the coming weeks. Obviously, with this trend, there's a concern we are going to have a really severe flu season. There's a hope, I suppose, that maybe transmission will be interrupted by the school holidays, because as I showed you, a lot of the transmission does seem to be happening in school-age children, but we won't, obviously there's no certainty around that. So I think it's good to prepare for the worst, and obviously the way we do that is through vaccination. So Tony, could you, I think the next graph, yeah, thank you. So this next slide just shows you where we're at the moment with our influenza vaccine coverage. And I guess there's a sort of mixed message. It's, I suppose just to start off with, it's worth saying there's definitely room for improvement. We're actually tracking better, I think, than we do historically, but less well than we did last year. And we really do struggle to get vaccination up in the younger age group, so the 6-month-old to less than 5 years, who are eligible for funded NIP vaccines. And that's always been the case. And I guess one of the real pushes that we have at New South Wales Health is to try and increase and targeting campaigns towards those groups, because we know that they are at relatively high risk of hospitalisation, and obviously there is a lot of room for improvement. And the other thing just to take home from this graph is as well that amongst First Nation people, the rates are generally lower, particularly in the younger age groups. And then finally, just no, that's good, Tony. Yeah, you can move on. Thank you. Finally, this is more just for general interest, I suppose, because you may have been seeing this in the news recently. RSV vaccines have been under development now for many, but probably decades, I think, and we're just beginning to see the fruits of that labour. So the FDA announced, I think earlier this year, that it approved a first RSV vaccine for those aged 60. That was one from GlaxoSmithKline. They all have almost totally impronounceable names. So RXV, I think that one's called. And it's also been approved now by the European Medicine Agency. And it's got reported efficacy in the over 60s of 83% against any lower respiratory tract disease and 94% against severe lower respiratory tract disease. So it does seem fairly efficacious. The FDA has also approved in the same age group a Pfizer vaccine called Abrivso, which has the numbers from the phase 3 trials are not quite so good, but similar. So it looks like it's got similar efficacy. And I guess from an Australian point of view, the important thing is that those two vaccines and also a Moderna mRNA vaccine are currently under evaluation by the TGA. So there may, and I believe the Moderna one in particular has been fast-tracked. So I think there may be some decisions made about those in the coming months, possibly even by the end of the year, which is quite exciting. All of these are being looked at in the over 60s. There are I think the FDA has been asked to review an application by Pfizer to look at RSV vaccines in pregnant women. That's the Abrivso in pregnant women. And I think there are some concerns from some of those trials that there have been some safety signals around premature birth. So I suspect that those are not going to move anywhere very quickly. So at the moment, really, where we're looking at is vaccines for those over 60. But it's an exciting time. So I think that's all I have in terms of the detail. Now, I also thank you very much. Just before I leave you, I've also got some. Jenny, are you able to pop up the slides about the Central Coast Hospital in the Home? I've been asked by my colleagues at my GP colleagues who run the Central Coast Health at Home program to just give you a little bit of a plug. Great, thank you. So I don't know how many of you are from the Central Coast, but for those of you that are, I think it's now been going for a year or two, a GP-led Health at Home program run by Dr. Ellie Warren and Catherine Palmquist, who are very long-standing GPs here on the coast. Could you just flick on to the next one? I guess the key message here really is that they have been given some extra resources to try and support the management of acute respiratory and gastro infections in the community this winter. Obviously, we're now seeing an increase in flu inspections, and so they're able to provide quite sophisticated support for people at home with this sort of monitoring equipment that I won't profess to understand to any great extent. But they also have RNs who can check in daily and escalate to GPs. So patients are fairly closely monitored essentially in the system. So I think people find that they feel fairly well assured that that patients can be cared for safely in the community. And so this program is, as I say, boosted for the winter. So to try and help us get through the respiratory season. Can you move on to the next one, Jenny? Great. And this is the most important bit, is how you actually do refer. So if you have patients who you think could be looked at home with a bit of extra monitoring and regular review, you can refer by providing a detailed referral letter and either email it to the email address at the bottom here, the CCLHD-CCH-home email address, or you can actually just call that telephone number to make the referral. So I guess this is a plug really to try and please think of availing yourself of this service if you do find patients who particularly this winter have flu-like illness or who you think may just need a bit of extra care to stay at home. So thank you.
Thank you very much. I'm just going to change the presentation over to Michelle.
All good.
Perfect.
So, thank you. Thanks, Jenny, and thanks, Tony and Richard. That's great. I'm glad to be back again. It's fun to be back. My name is Michelle Redford. I'm a GP in Newcastle and a GP advisor to Hunter New England Central Coast. And I want to start by acknowledging that I'm on the traditional lands of the Awabakal people and pay my respects to elders past, present, and emerging as well. So I'm going to talk a bit about some of the operational stuff and some of the primary care practicalities, and just reflecting on what Tony said, about immunisation. Although I am going to be talking a little bit about antivirals and other things, the key role that we have in primary care continues to be vaccination as an effective way to prevent severe illness from both COVID-19 and flu. So a few learning outcomes there. I'm going to go through some of the changes within vaccination, particularly focusing on the newer Moderna bivalent vaccine, which now comes in a single dose syringe. Hallelujah. I'm also just going to touch on some Medicare rebate things and some things about swabbing and masking, antivirals, all of these sorts of things. So this may already be a familiar slide, but just reflecting back on what Tony said as well, the key point being that if you're an adult and you have not had a COVID-19 booster or a COVID infection in the past 6 months, then you're advised to either consider or definitely recommended to have a booster dose. And that really depends on your age and risk factors. And as you can see, it's pretty easy to follow compared to some of the advice we've had in the past. So certainly very strongly recommended for everyone aged 65 and over, and also for people aged 18 to 64 who have any risk factors. But in fact, anybody aged 18 or over who has not had a booster can avail of themselves of one. And as Tony said, that's the key point for preventing mortality. The primary course doses are the same as they have been. The thing that has changed here is that now we can use bivalent vaccines for primary courses in older people, so not for children, but in people aged 12 plus. And there will always be a few people coming through for a primary course, but they're mostly going to be children. Remembering that there are specific vaccines for primary courses for these age groups. So if you're 6 months to 4 years, then you're going to have to be in a very specific group to need to have a COVID-19 vaccine. That's children with severe immunocompromise or very complex disability, and they need to have the Pfizer 6 month to 4 year vaccine. And because they're a high risk group, they get a 3-dose primary course. Otherwise, 5 years and over, there's a specific 5 to 11 Pfizer vaccine. Remember, everything is on Health Pathways. So these are the logins for both the Hunter New England and the Central Coast Health Pathways, which really are your go-to for the local referral and management information that you need. There is also open access for patients to a whole range of information via the patient info sites. So a little plug there for Health Pathways. Some very, very key pathways from the Central Coast, and the slides will be shared, so you'll be able to get that with all of the links. And this is one of the Hunter New England pathways, just highlighting where you can find all of that vaccination, immunization information there, so about recommended doses and vaccines. Remember that this is my top tip for navigating health pathways, which I probably mention every time, but on the far right side of the screen, you have an expand all button. And that means that you can then use Control F to find a word, like a word like steroids or something on the medication pathway for COVID-19. So that can be really helpful if you're struggling to navigate. So this is what I mentioned, that this is the change. So this is the most recent change to vaccination, that bivalent vaccines are now preferred over the original vaccinations for primary courses in people aged 12 plus. And there is a difference between which bivalent vaccine you get depending on your age, which I've just written down there. The message from ATAGI is that there is that both types of bivalent vaccines, so the 4-5 and the BA1, are offering similar levels of protection against serious illness and death. So it's not so much one over the other, it's more what you're able to get, bearing in mind that the BA4-5 is usable in everybody aged 12 plus, whereas the BA1 is 18 plus. There are no bivalent vaccines in those younger age groups, and so you have to use the original mRNA vaccines. So one thing about this is that if you are wanting to provide both primary courses and boosters, if your cohort is 12 plus, you really only need now to have either the Pfizer or Moderna bivalent BA4-5, and that will do you for all of your vaccinating in that age group. Obviously, if you're vaccinating people under 12, then that's a bit different. But it does give you that option to just have one vaccine on hand. Now, you may remember these sorts of posters from, a year or 2 years ago. It doesn't fit on one slide anymore. It's 2 slides. So this is the ancestral vaccines. You notice that AstraZeneca is gone. It's no longer available in Australia. These are probably fairly familiar, but as I said, the role of these vaccines is diminishing. We do still have Novavax there as the only non-mRNA vaccine. And then these are the newer bivalent mRNA vaccines, just noting the age differences with the BA1 being 18 plus and the BA4/5 being 12 plus. It's very detailed. You don't have to remember it all. It is on health pathways, but also introducing the Moderna bivalent, which comes in a single dose syringe. So it looks a bit more like a flu vaccine and not in a multi-dose vial. Just to remind you where they are on health pathways, so you can find them quite easily. So this is the Spikevax single syringe vaccine, comes in a box of 10. Bit of a game changer, really. I know a lot of practices anecdotally have been put off by the wastage with multi-dose vials, and although the official advice is that there's plenty of vaccine available and wastage is expected, this does give you the option of just doing more opportunistic vaccination. The vaccine can stay out of the fridge for, at temperatures of 8 to 25 degrees for up to 24 hours, and you don't need to dilute it. So potentially it is an easier option if you're going out to an aged care facility or visiting someone at home to be able to opportunistically take a single vaccine. Do make sure that you complete the online vaccination training if you're not already across that, because to be able to take on any of the newer vaccines, obviously you have to have done the module. Just another plug for the single. I was quite excited that we had a single syringe vaccine after all of the drawing up that we did in the early days. So there we are. That's the Moderna Spikevax vaccine. You just need to attach a standard needle. It comes thawed. We're very familiar with all of that now. Storage and receipt of thawed vaccines, and it has a shelf life in the fridge under strive for 5, etc. conditions of up to 30 days. COVID-19 vaccination pathway has all the information. You don't have to remember it all yourself. So moving on to Medicare, and this links in really with that idea of being able to get to some of the more vulnerable members of our society at home. There is still the flagfall item number available for COVID-19 vaccination, and that's for either a first service provided during a single attendance to an aged care facility or residential disability facility, or to a patient's own home if the patient is unable to attend another location. It has to be co-claimed with a vaccine suitability assessment, meaning that you have to actually give the COVID vaccine at the same time. But just remembering that there is that resource available to try and encourage vaccination of some of those vulnerable groups. The COVID-19 vaccine suitability assessment items have been simplified. Remember, the bulk billing incentive is worked into the vaccination item numbers, and we now have the same item number for whether it's the first dose or the second dose or the booster. None of that slightly more complicated plan that we had initially, and your item number that you use really depends on your whether you're MM1 to 7 and whether you're doing it in hours or out of hours. And the in-depth assessment item numbers are still available as well. It's only claimable once during a patient's lifetime, though, if you're having a longer consultation about COVID-19 vaccination. Those other bits and pieces about supporting access to antivirals, so that it's one of the few times when a patient can get a Medicare rebate for a longer phone consultation with their GP. More than 20 minutes is if they're being assessed for suitability for antivirals within 5 days of COVID-19 symptom onset. And those consultations are exempt from the 12-month face-to-face rule, so so patients can access that service from somebody who's not their regular GP. There are pretty complex requirements. I think, like with everything with Medicare, the devil is in the detail, and just make sure that you're across those. I've got a link on the next slide to that Medicare note. There are other 12-month face-to-face rule exemptions. If somebody is high risk, so they're PBS eligible for antivirals, and they're requesting PCR testing, then you don't have to have seen them face-to-face in the previous 12 months. Or somebody, whether they're high risk or not, a patient who's tested positive for COVID-19 in the past 7 days. So just to be aware, there are those ways of trying to support people over the phone or by video consultation without having to bring them into the surgery. So some other exemptions there, but I'm not going to go into that in great detail. These Medicare rebates were correct at the time of going to press. 1st of July is coming up. I think there's due to be a just under 4% uplift to patients' rebates on the 1st of July. So a bit more detailed information about Medicare on those websites. PCR swabs, so this has been a bit of a bone of contention, I think, but we're now in a situation where PCR testing is still available. It's just knowing how to get it organised for your high-risk patients, really. So with the cessation of nearly all the drive-throughs, most pathology providers now need a request form. I mean, the positive thing about this is that we'll actually get the results. We've struggled to get, as GPs, to get copied into the results throughout the pandemic. So, that's certainly a silver lining as far as I'm concerned. Without a pathology request form, the private fee is up to around $90 for patients. So what I'm trying to do is, if I identify a high-risk patient at their GP management plan or other consultation, just to give that patient a request form in advance and some instructions about rat testing initially, and then if they've got symptoms and their rat test is negative, or if they've had a very high-risk exposure, to try and get a PCR so we can get antivirals to them as soon as possible. I know that Douglas does still have some self-collect packs. We used those quite extensively a few months ago. You do need a referral form for those, and it's really worth trying to work out what you've got locally. I can't really tell you everything that exists, but Health Pathways can. And on the Central Coast, there's a website that links to a PHN website. There's the link, and on Hunter New England, we've got all the individual pathology providers and their requirements there. I mean, I'm certainly now seeing, a lot of respiratory illness, as I'm sure a lot of GPs are, and, doing a fair amount of swabbing as well. On to antiviral eligibility. So once you've got the swab result, and again, this is busy because it's PBS eligibility, just a couple of things to point out, really, because there have been a couple of changes. So one of the changes that came in the last few months is that if you're age 18 plus and you have previously been hospitalized due to COVID-19 infection, then you don't need to have another risk factor. That is your risk factor, and you are eligible under PBS for oral antivirals. Another change is that in the 60 to 69 age group, there is now a differentiation between which antiviral you're having. So you only need one additional risk factor to receive Paxlovid, but 2 additional risk factors to receive Lagevrio, molnupiravir. And I've listed some of those risk factors down below, but the full information is available on PBS. Hopefully we're pretty much across, a lot of these indications that haven't changed over time, the being age 70 plus, whether you have symptoms or not. It's straightforward. They're indicated. It's then whether you choose to have them and what your choice of antiviral is, which I'll come on to in a second. Happy to take questions at the end as well. So key things about prescribing are that Paxlovid is definitely so far ahead first line, and I'm trying so much harder, I think, now than I was maybe at the beginning to prescribe this using the Liverpool interaction checker and thinking about whether I can temporarily cease people's other interacting medications, with monitoring or whatever is needed to try and give them the most effective medication. The other key thing about it is that you do need to know what the patient's renal function is, and you need to give them quite specific instructions. But I know a lot of pharmacists will do this. If you've adjusted the dose, they will also go through the information. But bear in mind that a lot of the time, it's a third party that's going to pick up the medication. So, I think it's important for GPs to be across this. So because of the way it's presented, you have to essentially pop out the pill or get rid of it, or just know that you only take one of those 2 pink tablets if your EGFR is reduced to 30 to 59. So I think it's just helpful to see, that's how the packaging comes. Pre-assessment in aged care facilities remains really important. And I think that's another one of the key roles for primary care. This shows you the link to the pre-assessment form from New South Wales Health, which is actually a really useful document because it allows you to think in advance about antivirals for COVID-19, but also Tamiflu, whether that's for treatment or for prophylaxis in a person who's at risk. And it does guide you through that whole thing of checking the renal function and reducing the dose and making sure that that's appropriate, thinking about interactions. So that's where to find it on Health Pathways. You don't have to keep it all in your head. You see, it's on the pathway. And this is, again, reminding us about the dose reduction. That's also on the pathway. So Tamiflu, for treatment of influenza, this is from therapeutic guidelines, and the idea is to start as soon as possible and certainly within 48 hours of symptom onset. And some of those high-risk people are identified there in that list. Again, you've got to be aware of the dosing. It's not completely straightforward. Again, it's on Health Pathways. You do need to reduce the dose in renal impairment, but the standard dose for adults is 75 milligrams twice a day for 5 days. It's not on PBS, it costs about $40. And if you're giving prophylaxis, just a reminder, the dose is different. So instead of being 75, say for an adult with good renal function, 75 milligrams twice a day for 5 days for treatment, but 75 milligrams once a day for 10 days for prophylaxis. And again, that's a private script, but sometimes the PHU is able to provide that, for example, in an aged care facility in an outbreak. Again, this refers back a bit to some of what Tony said. So it's very difficult to find any kind of national guidance on what we should be doing in general practice. And so this is taken from a variety of sources and extrapolated a bit from the New South Wales Health guidance, but also looking at the RACGP guidance. And the message really is that we can still, and probably should, and we certainly are in our practice, continue with masking, with surgical masks in practice as one of our infection control measures. Obviously, it's not the only thing. There are lots of other things, screening and trying to prevent people with COVID from turning up and seeing us face to face unless it's completely and utterly necessary. And if it is, then making the safest arrangements we can to do it. But yes, it's still strongly recommended in general practice. We are allowed as private businesses to make it a condition of entry, and the RACGP has a number of resources and posters and things to try and communicate that. They also, are really highlighting that need to communicate that to our patients in advance so that expectations are clear, and also making sure that processes are in place to assess people who, for whatever reason, find it hard to wear a mask or can't wear a mask. And that's obviously often a good role for video telehealth. This is a bit of a busy slide. This is what we're doing in practice. And as Tony said, New South Wales Health's on yellow alert. And so this mirrors the different alert levels of New South Wales Health. It is pretty specific to our clinic. Some of the language that we use in it about specific types of roles and things is very specific, but essentially we're still in surgical masks, and if we are seeing somebody with respiratory symptoms, then it's a P2N95, which has been fit tested, and eye protection, because you don't know, they could have RSV, they could have COVID. They are not they're not all being rat tested before we see them, and so that's what we're doing. Again, as I say, this is adapted. There is no one national guidance document, but happy to take questions. And these are my questions for you. So I'm happy to take questions from you, but as part of our kind of trying to consolidate learning, this is a medical question Kahoot. You can scan the QR code. There's 12 questions, 30 seconds each. It's only going to take you 6 minutes, but the idea is that it will reinforce some of the ideas from the webinar and hopefully be a little bit of fun. This is what the first question is, just to give you a taster. So it's not too hard, hopefully. And don't forget to log your CPD, particularly if you're an RACGP member, and you can just quick log it to make it easy. I know everything changed on the 1st of January, but just a quick reminder. So happy to take questions. That's the Kahoot QR code. And I think we'll bring everybody back for questions. I'll see if there are any questions.
Thanks so much for that, Michelle. We don't have any questions at the moment, but I think Sandra is just going to have a very quick word and share a couple of slides. So I'm just going to share your screen. I hope that works.
Thank you. I've just got to make sure what you can see.
I can see your Google page. Oh, I could. Now I can see your health pathway slide.
Okay, so you saw this in Michelle's presentation, and thank you, Michelle, for sharing all of those pathways. And even though it said Hunter New England in the corner, Central Coast have exactly the same pathways. So you'll be able to find exactly the same information if you follow the links to the Central Coast slide. But I just wanted to show a couple more, just listen to everyone's presentations. There's a little bit more information that you might be interested in. So I'll just bring health pathways across here. As you all probably know by now, because we've been telling you for 3 years, all the COVID pathways sit here in the table of contents. And if you open it up, we've got a clinical, a practice setup section. And in there is a infection control and staff exposure pathway. And if you go down there, the information that's been shared around healthcare worker exposures is in a number of places. It's here under new and important changes, and those CEC guidelines that were mentioned, I think, was it Tony? Are here. You can click on them here. The other place you can click on them is right here, the healthcare worker risk matrix, which will take you directly to the information that you're looking for about when you can return to work. And it's also here under staff members who have tested positive. And Michelle, I'm not sure if this aligns with what you shared tonight, but we've also got the PPE suggestions there as well. And then the only other page I wanted to share with you was the influenza page, which might be of relevance given the spike we're about to see apparently. So that's all from me, and thank you so much everybody. That was a really fabulous presentation.
Thanks so much. Okay, well, we don't have any questions, so that means you've done such a great job that nobody had anything to ask, which is great. Don't forget that we will have a copy of this webinar up in our website in the education library. Don't forget that we have an education calendar on the website, and you can see all of the upcoming education that we have. Well, thank you so much, everyone, for giving up your time. Don't forget to fill in your evaluation when it pops up at the end. Thank you so much.
And your Kahoot. Do your Kahoot as well.
Oh, and don't forget the Kahoot. Yes, I nearly did forget. Thanks, everybody, and I'll see you next time.
Bye-bye.
Cheers, everyone.